What are the signs that you're actually having a heart attack? Because I'm told it's different in women than it is in men.
Well, women can present differently. For example, they might have the predominant symptom as shortness of breath instead of the classic textbook chest pain. Anyone can present differently. The classic is pressure-like chest pain, might radiate to the left arm, might radiate to the neck or jaw, nausea, sweating, just an overall feeling bad. Unfortunately, the most common presenting symptom is sudden death.
Welcome back to SHEMD. I'm Dr. Aliabadi. On today's show, I'm so excited to welcome my own cardiologist, Dr. Mohammad Ghalichi. It's important to know that heart disease is the number one cause of death in women. Today's episode is a real eye-opener. We're diving deep into why only relying on the standard lipid panel to assess your cardiovascular risk might not be enough. We've uncovered some crucial tests that can give you a much clearer picture and help you take control of your heart health.
On today's episode, we're so lucky to have you here, Dr. Mohammad Ghalichi. A little personal story. You are my sister's doctor. You're Thais' doctor. You're just an all-over badass in the field of cardiology and longevity, which we're going to find out about. So I'm going to read a little bit about you. You are an expert in cardiovascular medicine. You're double board certified in internal medicine. You're on the staff of Cedars-Sinai as a cardiologist, but you also have a private practice in longevity. And we're going to talk about what that means. I think it's important before we even get started to say that the number one killer of women is heart disease. And I don't think that women know that or people know that in general.
So cardiovascular disease is the global top killer. That's true for both men and women, and especially for women. And unfortunately for women, there's been a long tradition, including amongst clinicians, of being dismissive or believing that they're not at the same risk as men. And this leads to undertreatment of women. In the lay public, it's always just termed cardiovascular disease. What the disease is specifically is atherosclerotic vascular disease. And what that is...
Yeah, tell us what that means in layman's terms.
Yeah, so it's the very slow buildup of plaque in your arteries over time. And this is something that's nearly universal in human beings. There's just a lot of variability between people at the rate at which it occurs. And there are many identifiable risk factors that can accelerate this process. And again, it's nearly universal in human beings. And for women specifically, 1/3 of women will have a cardiac event before they're 65 years young. And that can be sudden death, that can be heart attack, that can be stroke.
Wow.
And we understand now the causal relationship for how this disease happens. And we have the technology to both identify someone's individual risk and to intervene to essentially take this outcome out of the likely possibilities of what will happen to them later in life.
Knowing your family's history of cancer is a first step to understanding your own cancer risk and may qualify you for the MyRisk Hereditary Cancer Test with RiskScore. It's easy, accurate, and covered by most insurers. Learn more at getmyrisk.com. That's GETMYRISK.com. What causes the buildup of plaque in women, and how do you test for it?
Yeah, that's an excellent question. So cholesterol is really, really important for the body. Nearly all the cells in the body have the ability to make cholesterol. And sometimes your body needs to shuttle cholesterol from here to there. Cholesterol is non-polar. It's like oil. And the blood is polar. It's made of plasma, which is mostly water. And so the cholesterol going into the blood is literally like mixing oil and water, and they don't mix. And so cholesterol can't travel by itself in the blood. It has to go in a vehicle. That vehicle in medicine we call a lipoprotein. So when you get your cholesterol checked with your doctor and you get your HDL, your LDL, those are high-density lipoprotein, low-density lipoprotein. So these vehicles are traveling around in the bloodstream and they can get trapped in the walls of your arteries. And when they get trapped there, it sets off an inflammatory reaction. Your immune system tries to go in there and clean them up. The result of this reaction is the formation of plaque. And this is a very, very slow process. It takes decades. And as the plaques get bigger, they start to go into the center of the blood vessels where the blood is flowing. They start to impede the flow of blood. They become blockages. And as the plaques get bigger, their risk of rupture increases. And it is a plaque rupture that causes the clinical disaster. So when a plaque breaks inside of a blood vessel, it's a site of injury. And when blood sees an injury, just like if you cut your skin, the blood will clot. So all of a sudden, a clot forms inside the blood vessel. It blocks the blood vessel. What also happens is fragments of the plaque will flake off. They'll travel downstream in the artery, and the arteries branch out like a tree into smaller and smaller branches. And then those fragments will get stuck there and the blood will clot there. And so that's the big clinical thing that happens. If it happens to occur in one of the arteries that gives your heart itself blood, what we call the coronaries, that's a heart attack. If it happens to occur in one of the arteries in your neck, the carotid arteries, and goes to your head, that's a stroke. It's a systemic problem. These plaques are forming everywhere. It's just that some parts of your body are much more sensitive to suddenly being deprived of blood and oxygen than other parts. So your brain, your heart, your kidneys, for example, they're very sensitive. And so that's the big problem that's occurring. And when someone has a heart attack, we have got very good as cardiologists at getting them to the cath lab within 90 minutes, what we call a door to balloon time, and stenting that artery open and trying to salvage the heart muscle and save that patient. But in reality, that disease started decades earlier, and there was an opportunity to intervene from way back then.
This is the best simple explanation I've heard.
I've never heard it
in my
that
life.
clear, to be honest. But I do have some questions about this. When does the plaque start forming, and what can you do to stop it from forming?
Yeah, so we realize now that it starts at birth, maybe even in utero, and it starts at that time and it occurs very slowly, very indolently, insidiously. For example, there are many people who happen to die, say in their late 20s, early 30s of something unrelated like a car accident. And at autopsy, when we look at their arteries at the microscopic level, at the histological level, we can already see that there's evidence of this disease that has started. For women, the majority of women will have evidence of microscopic levels of this disease by the time they're age 40.
So if all these changes happen to women before 40, how do you monitor a patient? When do you start seeing these patients as a cardiologist?
I would advocate that every patient, by the time they're age 18, should have a lipoprotein lab test. And this standard lipid panel that's often done by doctors is insufficient. So in a standard lipid panel, some of the main components of it, like LDL-C, is calculated and not directly measured. We have the technology to measure it now. And there are parts of this that are genetic, like there's something called lipoprotein (a) that 15% of the population has. That's not even part of a standard lipid panel that many young women might have. And you would want to know about it at an early age because it can accelerate this disease. Also, there's a lab test. It's called ApoB. And ApoB is a much better single blood test. If I had to pick one blood test to assess risk for this, that's the one I would pick, because you can think of it as a collective measure of all the atherogenic particles, meaning particles that can cause plaque that are circulating in the blood. So the first part of the answer to that question is every woman should have their ApoB and Lp(a) checked by the time they're age 18 at least once. And if they have a strong family history of this, maybe even earlier.
I don't think I know of a pediatrician or a primary care doctor who does this at age 18. Is this common practice or is this a newer practice?
It's unfortunately not common practice. Even, I'm embarrassed to say, many cardiologists are not that familiar with ApoB and lipoprotein (a). In lipidology circles, physicians who specialize in studying this, It's very well known, been that way for quite some time. And there are indeed many cardiologists that do this in their patients and they advocate for it. And it's really not that difficult to do. There are many labs that can do it.
Can I ask you a question?
Yeah.
So here you have an 18-year-old who tests positive.
Or is there levels?
So there are degrees of this. And historically, even for patients that have something called familial hypercholesterolemia, where there's very high levels of these lipoproteins in the blood, there has been a tradition of undertreatment and saying you're too young to be treated, for example. The disease, you could think of this as how it occurs is the area under the curve with how high your lipoproteins are and for how much time. And so the higher they are, the shorter the time duration needs to be in order to develop advanced stages of this disease. And the lower the level, then the longer the duration. There are some people that won the genetic lottery and they have very low levels of ApoB and LDL cholesterol lifelong. And so when we're all very young, our LDL, for example, is usually between 20 and 30. And then this deteriorates as we get older. And there are some people that genetically it just persists this way over time. And they never get atherosclerotic vascular disease. It just doesn't really exist in that population. Conversely, there are people that have very high levels of this same thing, and they get accelerated cardiovascular disease. And so if your goal is longevity and you want to change the whole paradigm into not waiting until there is a very late stage clinical problem and you're trying to play, just address problems after they show their face instead of anticipating them, then you would want to check this earlier.
What you're sharing is incredible because even as a physician, I have daughters. I have a 19-year-old and a 17-year-old. They do their regular lipid panels through Quest or LabCorp or different labs, but I can guarantee you that the ApoB has never been checked.
Yeah, they probably haven't. Most patients haven't. And when the levels are elevated, the guidelines use a 10-year risk calculator to decide if you should do something about it today or not. And so let's think about that for a second. So if you have a disease where you understand the causative nature of the disease. So for example, let's say smoking and the development of emphysema. So if someone is smoking 10 cigarettes a day and you can't see evidence of lung damage on their chest imaging, you would never tell them, just keep smoking until I can see it.
True.
And you can keep on just doing what you would do. Because you understand the causal nature of this problem, you would try to get the smoking to zero at all stages as quickly as possible. And we now have the technology, namely very good pharmacotherapy, where we can intervene and lower their levels at a very young age. And this would, if you make a small change early on, it will compound with benefits over time so that you don't get this disease.
Do you ever treat an 18-year-old?
Yes. And it is a nuanced discussion. It really depends on how high the lipoproteins are and what their wishes are. And I do have some patients that have come to me after seeing multiple other providers where the patient wanted treatment, they understood, they did their own research, and the providers refused to give it to them. And, I believe in shared decision making. And a lot of times people can understand this problem if you explain it to them. And so then I do offer them an avenue to treat.
Are there natural things you can do that aren't taking medication that could treat this?
So it depends if it's genetic or not and how bad it is. In general, there are many things that one can do to prevent this disease from progressing. So for example, exercise in it of itself is one of the most protective things anyone can do, as effective, if not more effective for your longevity than almost any medication.
Any kind of exercise?
For this problem, cardio exercise specifically, now in the world of longevity, many other types of exercise are important. So for example, for a woman, as women get older, they can become more frail. Their bone density can go down, their muscle mass can go down. And then when they get older from a ground level fall, they fracture their hip, they end up in the hospital for 6 months. And so to prevent that frailty from early on, I usually advocate for women across the board to incorporate resistance training as a type of exercise. And again, if you do these small interventions early on, they compound incredible benefits over time. And you don't have to train so intensely for performance for some event. You're just training enough to maintain your muscle mass, knowing that as you get older, you're going to have to draw from these reserves and there's going to be an obligatory decline in muscle mass over time. And you want that line to be very flat.
But if you have cardio disease in your family and you're genetically predisposed, you need cardiovascular exercise. That's a
cardiovascular exercise is one of the most protective things you can do. Other things you can do, very good control of blood pressure if that was a problem. Trying to keep visceral fat down, your metabolic health is really important. If someone has metabolic disease, if they have insulin resistance, diabetes, for example, it accelerates, they get more of all the other top killers. So diabetics, they get more heart attacks, more cancer, more dementia, more strokes. It's just bad all around.
Besides cardio, workout, what are the other things that you can do?
Well, I want to emphasize that if someone, especially at a young age, has very elevated lipoprotein levels, that probably they're going to need pharmacotherapy, meaning medications. And I know that no one likes medications. I'm in that camp. But there are some situations where the benefits far outweigh the risks. And this is one of those. And you can do some things with nutrition, for example. If you're very strict about dietary fat, restricted intake, carbohydrate, especially starchy, refined carbohydrates, you can, if you take the whole population of people, probably reduce your lipoprotein levels, maybe 10 or 15%. That will probably be insufficient, especially if you have a young person that's relatively fit. Sometimes they're super fit and they have very high genetic levels.
Genetics play a big part, right?
Genetics play a huge role. I would say for lipoprotein levels, about 80%.
Wow. A lot of patients get their labs done through Quest, through LabCorp, through these big labs. But when patients come to your office, you do specific blood tests on them. Can you tell me which lab you use and how often you do it?
Yeah. So initially, for most patients, I try to use a best-in-class lab. Labs that I generally use are Cleveland Heart or Boston Heart. We draw the blood in my office, and for Boston Heart, for example, we pack it on ice and ship it overnight. And the reason that I do that is for some of these tests, they're very difficult to do. So for lipoprotein (a), for example, you have to simultaneously measure the size and the density. And so a lot of labs don't get it right. And so I just know that I feel more confident that I can trust the results, especially for an initial evaluation. To answer what main labs would I do? So at a bare minimum, I would say advanced lipids, which includes ApoB and lipoprotein (a). For many patients, I will measure the LDL particle fractionation, the size. This gets very nuanced, but basically the more of these particles you have in your blood, the more opportunity they can get trapped and cause plaque. The smaller they tend to be, the more likely they are to be trapped. And so all of this does factor in deciding someone's risk. And there are inflammatory markers that we also check to get a sense of, is plaque forming? Because again, this disease is a lipoprotein inflammatory disease. And so there's a lot of data there, but at the bare minimum, ApoB and lipoprotein (a). For longevity, there are many other labs that I might check.
Do you have those days when you're just feeling off, maybe a bit sluggish or dealing with headaches? You may not even know it, but you might be dehydrated. I say might because I had no idea how dehydrated I was until I started giving my body the electrolytes it so desperately needed with Element. After I started taking Element for a few weeks, I really noticed a difference in my brain fog and energy level. And I love that Element is free of sugar, artificial colors, and other weird ingredients found in popular electrolyte drinks, so I don't have to worry about what I'm putting in my body. I try to take one every day, but I definitely have one when I'm working out, especially when I do my hot yoga classes. That's a necessity. Get your free Element sample pack with any purchase at drinkelement.com/SHEMD. Also try the new Element Sparkling, a bold 16-ounce can of sparkling electrolyte water. It's finally summer. I wish I could spend every day at the beach, but there's truly nothing better than the smell of the fresh ocean breeze on a hot day. But recently I've been using Osea's Undaria Algae Body Oil that brings that feeling right into my daily routine. And you guys, I'm obsessed. I literally get out of the shower and I slather that oil all over me. I'm always looking for ways to keep my skin looking fresh and young. And Osea's Undaria Algae Body Oil is proven to instantly improve skin's elasticity and deeply moisturize. I'm serious. I've been putting it on every day after the shower, and I've noticed a huge difference in the texture of my skin. I love that knowing Osea's products are clean, vegan, cruelty-free, and climate-neutral certified. Dr.A and I created SHEMD to empower women, and I absolutely love that Osea is a woman-founded and led company that has been making seaweed-infused skincare for over 28 years. Get healthy, glowing skin for summer with clean, vegan skin and body care from Osea. Get 10% off your first order site-wide with code SHEMD at OseaMalibu.com. You'll get free samples with every order and free shipping on orders over $60. Head to OSEAMalibu.com and use code SHEMD for 10% off.
Walk me through a patient, let's say a 40-year-old woman who comes to your office. How often would you follow that patient?
It really depends on the patient. So in the first visit, we might spend an hour, and I'll make sure that she doesn't have any cardiac symptoms. I'm going to do the cardiac exam and make sure that that's normal. I'm going to do an EKG. I'm going to go deep dive into her family history. Has anyone had a heart attack, heart stents, bypass surgery, stroke? How old were they? Were they smokers? How are you related? Dementia history in the family, stroke history, cancer history. All of this is very important. And then we will do the blood work. And if that patient wants to be very proactive, we will often do imaging. The blood work gives you a confident assessment on if someone is forming plaque today and at what rate. But the first time that I meet them, it's possible that they may have already formed plaque. And so we can do some imaging tests. And so there are three really useful ones, in my opinion. One is called a CT coronary calcium score. And what that is, I think of it like a mammogram for your heart. It's a tactical focused CT scan of your heart. It does have a very low amount of radiation. It's usually about half a millisievert, which is analogous to 5 chest x-rays. And what that test is looking for is calcium deposition on the coronary arteries. And so if you have calcium, that's a late sign, and you know that patient, you need to be a bit more aggressive in treating them. A 0% calcium score is wonderful. It doesn't rule out this disease. And most people form this disease very slowly. And by the time it's showing up as calcium on the scan, it's very late. And so if the blood work suggests they're forming plaque aggressively, even with a 0 calcium score, we will usually have a discussion and I will offer them intervention to break that cycle.
At what age does somebody go see a cardiologist and get these tests?
For most of the things that I do, it has the most payoff for most people around age 40. When people are younger than that, they often feel that they're invincible and they're not very motivated to be very proactive about a lot of these things. Once people hit the age of 40, some of these imaging tests, the probability that they become positive goes up. And those patients are more interested in making a change.
It's because at age 40, everything starts falling apart. And then we're sort of realize that everything that should have been up here is now down here. I also have this really important question because I think about this all the time. I'll be exercising and I'll feel something on my neck. And I'm like, I'm having a heart attack. It's tight. What are the signs that you're actually having a heart attack? Because I'm told it's different in women than it is in men.
Well, women can present differently. For example, they might have the predominant symptom is shortness of breath instead of the classic textbook chest pain. Anyone can present differently. The classic is pressure like chest pain, might radiate to the left arm, might radiate to the neck or jaw, nausea, sweating, just an overall feeling bad. Unfortunately, the most common presenting symptom is sudden death. And people don't realize that. And that's why you have three main coronary arteries that give your heart blood. And the one that runs on the front, called the LAD, is nicknamed the Widowmaker. And the reason for that is because many people find out they have a problem there by dying suddenly.
You were talking about imaging. And when someone comes to your office at age 40, you said they start with a coronary calcium scan. Do you start that at 40 or 45? And what are the other tests? You said there were 3 tests.
So I have patients that have a positive CT coronary calcium score in their 30s. And generally, I don't recommend that they do the scan until they're 40, unless there's a strong family history of ischemic heart disease, especially at younger ages, or when they do their blood work, there's clearly elevated risk, that their labs are pretty abnormal.
So they start at 40, they do their coronary calcium scan. What's next? What else? What other tests do you do in a 40-year-old?
Well, so if the test is strongly positive, or if that patient has any symptoms, or if the patient is just very motivated with longevity, we might consider doing a CT coronary angiogram. And a CT coronary angiogram is different than a CT calcium score. It involves placement of an IV and a contrast injection. It also involves more radiations. That test actually maps out the arteries, and then you can see non-calcified plaque, which is a limitation of the CT coronary calcium score, and you can get a specific range for blockage. You know, this part of the artery is 20% blocked, for example, as opposed to there's just calcium there or not. So it does give more information for sure, but it comes with the trade-off of the contrast and radiation exposure. And the third test that I find very useful in my practice is a carotid artery ultrasound to measure the intima media thickness. The intima media is the inner lining, the wall of the artery. These arteries are so close to the surface of the skin that we can see them well with modern ultrasound technology, and we can see without radiation exposure early non-calcified plaque developing. And this test, unfortunately, is very operator specific. And so you need to be skilled at doing it. You need to have practice. You also need really good equipment. I did an extra year of fellowship for advanced cardiac imaging. And on my patients, I do the scan myself. And so I'm able to track them over time. And the added benefit of this test is for many patients, when there is a plaque, I show them the plaque right there. And many patients might be hesitant to initiate pharmacotherapy to break the cycle for forming atherosclerotic vascular disease. But when they're looking at plaque facing them in the face, they usually become much more amenable.
44% of all women in the US have high blood pressure and are on some form of medication. A great example is my sister. She came in to see you for a gynecological visit, and Thais took her blood pressure and sent her directly to you because it was so high. And that's not normal for my family. We don't have heart disease and we all have really low blood pressure. So she went and saw you. Do you have to take medication for high blood pressure? Are there natural things that you can do? What do you do when you see a woman come in and her blood pressure is that high?
It depends on how high the blood pressure is, and it really depends on the whole picture here. So most people, if they're lucky enough to live long enough, they will develop high blood pressure. And the mechanism for that is as we get older, our arteries become less elastic, less compliant, and as they become harder, when the heart pumps, the pressure goes up. But for younger people especially, there are many other factors that contribute to causing high blood pressure. So for example, if someone exercises a lot, that does lower blood pressure, cardiovascular exercise. Another thing is if someone is not sleeping, if they have insomnia, I don't feel that medicine adequately attributes enough importance to stress as well. And so if there's insomnia, if there's lots of stress, cortisol goes up. This elevates blood pressure. In fact, there's a normal variation in cortisol levels in our bodies, and they spike usually around 5 a.m. And there's more heart attacks at that time. There are a lot of factors here. And so if someone has secondary factors to cause high blood pressure and their blood pressure isn't really severely high, I think it's worth trying to address those first and giving a trial of, say, 3 months to see if they can improve that metric. There are many other factors. So, for example, there are lots of patients, I would say it's an epidemic, that they're on stimulants. They're on Vyvanse, Ritalin, Adderall, Strattera, and these drugs can cause high blood pressure. There are many other medications that can cause high blood pressure. And sometimes you can reduce the dose to a minimum effective dose. Sometimes you can even change their therapy, and then that removes the problem. There are other factors too. If someone has untreated sleep apnea, if they're obese, all of these things can factor into high blood pressure. And then there's also assessing what someone's blood pressure really is. And so it's important. I teach all of my patients how you properly take your blood pressure. And
how do you properly take your blood pressure?
Sure. So with an inexpensive cuff that I usually help them buy on Amazon, you need an arm cuff, not a wrist cuff. You're sitting at least 5 minutes. Both feet are on the floor. Your legs are not crossed. And you use the arm cuff and you keep that about the level of the heart. And then it's the first check. And the way the Mayo Clinic does it, which I think is the best way to do it, is they make their patients check it 2 times in the morning, 2 times in the evening with the heart rate, record it in a log, and they make them do it for a month. I usually tell the patients at least do 2 weeks. Sometimes it's like pulling teeth to get them to do it. But then you get a much better picture of what their blood pressure really is. And it doesn't take $1 million to figure this out. And it is a very important thing to address, because if you leave the blood pressure high, just like the lipoproteins, for a long period of time, it's putting stress on the heart, the kidneys, the small arteries in the brain. We know that the evidence is just overwhelming that there is an increase in all-cause mortality. There's an increase in heart attacks. There's an increase in strokes if you just leave your blood pressure high.
This week, I sent a patient to you who's relatively young, in her 30s. She had preeclampsia, which is high blood pressure, with her last pregnancy. She's pregnant again, and in her early first to second trimester, her blood pressure is borderline. It was like 138/89. And I sent her to you to rule out basically chronic high blood pressure. So I don't confuse it with preeclampsia later in her pregnancy. Can you talk to us about high blood pressure in young women, especially during pregnancy?
Sure. So some women might develop gestational hypertension, so high blood pressure in pregnancy. And then after the pregnancy, that resolves on its own. It is a risk factor to developing high blood pressure even outside of pregnancy. There are many things to keep in mind for a woman going through pregnancy. So there's always this balance where you don't want to give medications that might potentially interfere with the pregnancy, affect the fetus, for example. Women generally, I find, are very concerned, and appropriately so, about taking anything. And there are thresholds that are commonly used, usually 140/90 millimeters of mercury, maybe, for when you might initiate therapy. In general, for the patients, especially at an older age, I'm very aggressive trying to get them to check the blood pressure consistently. And as they approach the 3rd trimester, as they approach delivery, problems like preeclampsia may start to show their face when they wouldn't show earlier on.
And I want to make sure patients understand that, up to 6 weeks postpartum, you're at risk of still having blood pressure issues related to the pregnancy. So they need to call their doctors. And we're going to cover that on a different episode. Let's go to me. Because at age 48, I had a negative calcium scan, negative coronary calcium scan, and I was very excited. And when I recently did my blood test, regular lipid panel, that's when I got the call from you saying if I wanted to live to be 75, I was probably okay. But beyond that, I needed to come see you. So when I came to see you, you did the comprehensive workup, as you mentioned, but you also did my labs through Boston Heart, and which I think it's an out-of-pocket cost because I just got a call from them. I think I need to pay something. I don't know what that amount is. Do you know what that amount is for patients who want to pay out-of-pocket?
It depends on what they offer. A lot of tests, and that includes genetic tests. And it also depends on your insurance carrier. And they're in network with some carriers, but they're out of network with many other carriers. And so this gets very nuanced. And it also depends on what someone's deductible is and things like that.
And so it might be covered by insurance.
It might, yes. And there are some that it is covered, and Medicare it's covered.
And so what are the main tests that you did on Thais that you think that most women should do at Boston? Let's go over those.
Okay, well, I have a copy of her.
Yay, I love that you get to be the guinea pig right now.
So my life is public. So before we get this, and I want to let our listeners know that I think it's important, especially if this test is covered by insurance, for every single patient to find a physician or a cardiologist near them and do this blood test. The reason I asked Dr. Ghalichi to come on this show and publicly talk about these blood test results, because sometimes doctors don't understand what these values mean. And I've asked him to go one by one over these results. So if you have a blood test results from Boston Heart and it's in your hands and you don't know what it means, that's exactly what he's going to do today and go one by one and explain it for us. So I'll have you start.
Okay, no problem.
Start embarrassing me in public.
Well, I'm happy that you did these tests. I really am.
So I think it's really important as we talk about these tests. The reason that we want you to do these tests is so that you can, first of all, take your own health into your own hands and understand your body and your heart and all of that. But also this is longevity. So we're trying to prevent disease before it happens. And I think the medical industry right now has it backwards. They're about treating you once you get a heart attack, once you get the plaque. This is what you need to do in order to find it early so that you can take preventative measures.
Yeah, unfortunately, with the way that our medical system is set up, most encounters are, the main objective is, what is the problem right now?
Right.
And if there's none, it'll be very brief. And it's really only addressing that. It's not what is potentially your problem 20 years from now, and what can you do about that?
And before we get to my lab results, I want our audience to know that, you know, my BMI is 22. I believe it's 22. I'm about 5'9", and my weight is about 137. And I have normal blood pressure, a negative coronary calcium scan, but my Boston Heart results were completely abnormal.
Yeah, so let's go through some of these labs. So as I mentioned before, if I had to pick one test on here as the only test piece of information that I had, it would be the ApoB. So yours is 142, which is quite elevated. And ApoB, you can think of it as the collective measure of all atherogenic particles in your bloodstream, all particles that can cause plaque.
What, in your opinion, what should the ApoB be?
So a good ApoB would be below 60. And if you want it to be perfect, it would be 20 to 40, which is the level that we have when we are very young. And if you want to eliminate atherosclerotic vascular disease, you know, essentially just stop it in its track, then ApoB of 20 to 40.
Did y'all know that the indoor air that we breathe can be up to 100 times more polluted than outdoor air? I had no idea until I heard about Air Doctor. There's allergens, pollen, pet dander, dust mites, mold spores, and even bacteria and viruses inside of our homes that we can't see. And Air Doctor filters out 99.99% of these dangerous contaminants so your lungs don't have to. The Air Doctor air filter has been really helping with my kids' allergies a lot ever since I put one in their room. And I really noticed that they seem I'm way less congested. If you want to be breathing clean air, I highly recommend getting one. Air Doctor comes with a 30-day money-back guarantee. So if you don't love it, just send it back for a refund, minus shipping. Head to airdoctorpro.com and use promo code SHEMD, and you'll receive up to $300 off air purifiers. Exclusive to podcast customers, you will also receive a free 3-year warranty on any unit, which is an additional $85 value. Lock this special offer by going to airdoctorpro.com and use promo code SHEMD. My kids and I rarely fight, and when we do, 9 times out of 10, it's about their screen time. I try everything in my power to get them to understand that being in the moment is so much more meaningful than watching someone else's memory on their phone. If you have kids and you're looking for activities for them that don't involve screens, you have to try KiwiCo. KiwiCo sends these awesome crates full of hands-on projects every month. I just ordered one for my nephew, and we built a little robot together. He loved it, and so did I. It was such a great bonding experience, and the best part was watching him have that sense of accomplishment when we finished it together. Seeing his eyes light up with curiosity and excitement was priceless. KiwiCo has so many different activities that are designed to introduce kids to cool science, technology, and art concepts. One month they might be engineering robots, and the next they could be learning about the science of ice cream. It's always something new and exciting. It's like getting a treasure chest of creativity delivered to your door every month. Redefine learning with play. Explore projects that build confidence and problem-solving skills with KiwiCo. Get 50% off your first month on any crate line at kiwico.com with promo code SHEMD. That's 50% off your first month at kiwico.com. Promo code SHEMD. Okay, what's the second most important test?
Well, in this case, it would be the lipoprotein little a, and hers is elevated at 100. So lipoprotein little a is a genetic lipoprotein. About 15% of the population has it. It is not part of a standard lipid panel, and so it's completely missed in the majority of cases. And there is a varying expressivity in lipoprotein little a, meaning it shows its face in some people and not for others in causing this disease. But in general, it's pro-atherogenic, meaning it accelerates the plaque formation. It's pro-thrombotic, meaning it increases the chance of forming clots. And it's pro-inflammatory.
And what should it be?
Negative.
Negative?
Well, let me clarify.
I'm like an F here. My grade is an F.
Well, let me clarify. So human beings, Homo sapiens, have been walking around on this earth for nearly 300,000 years. And our genes are mostly adapted for ancient environment. So the human environment changed very rapidly. And although our genes do change, they change very slowly compared to that environmental change. So there is evidence that in an ancient environment where, for example, you might be running around in the forest getting cut on rocks and bleeding out, or you might have a parasite in your body with no treatment available to you, that having a pro-inflammatory state, a pro-thrombotic state would be an advantage. So when you say what should it be, I am assuming you mean today in our modern environment for someone who's interested in not dying of a heart attack or a stroke and living as long as they can, well beyond their reproductive years.
What should it be? Negative?
The most optimal result for lipoprotein little a would be for it to be negative, less than 20.
And so what does Thais do in order to get these to optimal? Does she have to take medication?
Yes. The short answer is yes. For lipoprotein little a, we do have one class of medications. They're called PCSK9 inhibitors, Repatha and Praluent, that do lower lipoprotein little a. In the drug development pipeline, there are some drugs. There was one presented in October of 2023 at the American Heart Association, pelacarsen, that it's an injection once a year, and it lowers lipoprotein little a levels by 94% at the 1-year mark. But it's in its last phase 3 stage to see if it will translate into improved clinical outcomes. And so we know that the drug does lower lipoprotein little a. We know that it's generally safe as far as we can tell. What we don't know is, will this translate into less heart attacks, less strokes, less death? Almost everyone has heard of statins, and these are medicines like Crestor and Lipitor. So statins have been around since the late 80s. We know that they work really well. They decrease the synthesis of cholesterol in the body, and they do translate into improved cardiac outcomes. Statins, unfortunately, are a very polarizing medication. It's kind of like the COVID vaccine or presidential politics. There are people that believe that statins are killing people. There are people that believe that statins are so miraculous they should be in the water supply. I'm in between. So they do work really well. They do have potential side effects. And so I explain that to patients. So statins can, for example, some people are very sensitive to them and they get muscle aches.
Mm-hmm.
Some people will get elevated liver enzymes. They can potentially worsen your insulin resistance. Some people actually move to the threshold of having diabetes. It's a very small percentage, but we know that it exists. And then some people, this gets to be more subjective. They complain of a temporary brain fog. And the way that that mechanism is believed to be is that statins are blocking the synthesis of cholesterol everywhere they go, and they do cross the blood-brain barrier, and your brain needs cholesterol just like everywhere else, and it can make its own, and it's decreasing the synthesis there. The good thing about statins is all those side effects are reversible, and they also cost nothing. And so that's one huge advantage.
We were told on a different podcast in terms of statins that all the clinical trials were done on men, that there were very few trials done on women.
Historically, women have been underrepresented in cardiology trials across the board, and that includes trials for statins. There are some that are more recent where a higher percentage of the population were women, and there have been so many trials with so many people that even if you tease out the women, it's pretty clear that they do work for women.
What's the third group of medication you were talking about?
So beyond that, there's another medicine called Zetia, also called ezetimibe. And what that medication does is it blocks the reabsorption of cholesterol in the gut. By itself, it's usually not incredibly effective, maybe a 20% reduction in your lipoprotein levels, but it is well tolerated and it's very inexpensive. There's another new medication. It's called bempedoic acid. The brand name is Nexletol. It also comes in a version called Nexlizet, which is a combination with ezetimibe. And what that does is it blocks the synthesis of cholesterol, but only in the liver. So it has this neat trick where it is a prodrug and it needs to be converted in the liver in order to work. And it doesn't go all over the body, so it wouldn't cause the muscle aches, for example. It shouldn't cause that brain fog, for example. The drawback of bempedoic acid is that it's maybe 20 to 25% reduction in your lipoprotein level, so it's not as effective as statins. It's also close to $400 a month without insurance approval. It's a newer medication.
So you just covered 4 different treatment plans for patients who have the little a lipoprotein little a and the ApoB. What percentage of patients with elevated ApoB and this LP little a have high cholesterol on their labs?
Well, the ApoB is really an indicator of high cholesterol. Some people will even say that the LDL cholesterol on a standard lipid panel is sort of a poor man's ApoB. And so on a standard lipid panel, unfortunately, LDL is often calculated instead of measured, and that formula is not perfect. And so sometimes we get an erroneous value. But even when you do a better test and there's a direct LDL, LDL does cause plaque, but it's not the only particle that can cause plaque. And ApoB encompasses the other particles that could cause plaque as well.
So in my case, my cholesterol was up, my ApoB was up, and my lipoprotein little a was also up. What else in my blood test values are concerning to you?
Other markers that I pay attention to, these are more nuanced. They're not quite as critical as things like ApoB or LPA. But on the bottom right, you have desmosterol, lathosterol. These are cholesterol production markers. And where this might become clinically relevant is if you are at all worried that you have decreased the brain's cholesterol synthesis. So, for example, if someone is concerned about dementia, they're at genetic risk for dementia, you give them a statin, it shuts down the desmosterol, it shuts down the brain cholesterol synthesis, desmosterol levels plummet. There's no reason we have to do that to someone. Today, we have other tools that can lower their lipoproteins without decreasing that production. On the bottom there, campesterol and beta-sitosterol, these are plant sterols. Unfortunately, there are many people who believe that anything from a plant would be healthier. And some people are actually supplementing by taking what are called phytosterols, which are plant sterols. Our bodies have evolved two mechanisms to prevent the absorption of phytosterols. So in the gut, they are blocked from coming in. And then there's another mechanism that if they accidentally get in, they're kicked back out. And elevated phytosterols in the blood are associated with more cardiovascular disease. And so anytime I see a patient supplementing with these, I tell them to stop immediately. And what this means here in this context is that the absorption markers are very high. So Dr. Aliabadi's absorption...
While you're grilling me, you can call me Thais because I'm your patient now.
All right.
And I failed my test.
Well, so Thais's absorption markers are elevated. That implies that her gut is very efficiently absorbing dietary fat.
No, it's not a good thing.
Oh, it's
I'm absorbing. Oh my gosh, she's high-fiving me.
It's a good thing in an ancient environment where you don't know when your next meal would be.
Right.
Today, in a modern environment, it can be counterproductive. And it also implies that if she were to take a medicine like ezetimibe, which blocks reabsorption of cholesterol, she might get more benefit than average.
You were just saying that if you have risk for dementia or genetics in your family, the ApoE4, you wouldn't take statin. Did you say that?
No, the evidence shows that statins, if anything, have only a protective effect for dementia.
Okay.
And that's across the board. And there's been a lot of concern out there in the public that statins are accelerating dementia. There's absolutely no evidence for that. There are clinics that specialize in the prevention of dementia for people at genetic risk for dementia who do not yet have dementia. There was a clinic at Cornell, for example, and they've been very generous of sharing what they do.
Is that Dr. Isaacson?
It is.
Yeah.
Yeah, Richard Isaacson. So there is a clinical concern that statins might cause a brain fog. And if someone is at increased risk for Alzheimer's disease and they take a statin and their desmosterol levels plummet, which the threshold used is usually 0.8, there are clinics, although we lack sufficient evidence to know that this is the case, there are clinics that will take the patient off of a statin and instead use an alternate agent that doesn't lower the desmosterol level, because why take the chance?
Right.
And they still do tight control of their lipoprotein levels, which is a known thing that someone can do to lessen their risk of dementia.
We learned that the two most important labs to look at are the ApoB and the lipoprotein little a, which is marked as LPA. Ideally, you want your ApoB to be anywhere between 20 to 40 and the lipoprotein little a to be less than 20.
Yes, and I want to clarify a few things. So one is, for patients, they only need to check the lipoprotein little a once. It's genetically determined. You either have it or you don't. And currently, we don't use that as a target for therapy. That may change, but for patients who have a negative lipoprotein little a, which is going to be 85% of the population, they don't have to do that test again. And so it's cost saving in that way. The ApoB, personally, my opinion is perfect. Levels are between 20 and 40. I try to push my own levels down that low, but that is not the guideline. Right. And so I tell patients that, because this becomes really important with what other providers are going to suggest or what insurance is going to pay for. And so ApoB is not even used in the guidelines as the target. I think it should be the target, and that it's usually LDL cholesterol. And the guidelines are less aggressive than I think they should be because, again, they use a 10-year risk calculator and they only intervene at later stages of the disease when we could intervene very early and prevent the whole thing altogether.
How often do you check your ApoB?
Generally, for patients, if they have evidence of coronary artery disease, atherosclerotic vascular disease, I try to get them to check it at least once a quarter. At minimum, I would say 3 times a year.
Again, this is why it gets a little confusing because you just made a good point. You said that checking the LDL is what most doctors do, and that's what they're looking for. But you think that the most important thing to check as a patient is your ApoB and your Lp(a). Is that correct? I just want to be really clear with everybody because if there's I think that it's so confusing out there. You get all this these are the things that you need to do if you've got heart disease in your family. These are the tests that you should make. So as the expert in the field, you're saying that those 2 tests are the most important, more important than your LDL.
Yes, absolutely. So I'll try to simplify it. If I had to make a broad recommendation, I would say that every person should have their ApoB and Lp(a) checked at least once, ideally by age 18. But if it hasn't happened, at least once. If the Lp(a) is negative, which is genetic, you don't need to worry about that anymore. If the ApoB is elevated, then that needs to be addressed. You're trying to figure out how many particles are in the bloodstream that can cause plaque. We call them atherogenic particles. Most of them are LDL for most patients, but there are other particles that also do that are included in ApoB, but they're not included in LDL.
Okay. So you can see them if you test for the ApoB, but you can't see everything in the LDL.
That's correct.
Okay.
Fantastic. So we summarized the first page of Boston Heart. Thank you for that.
Whenever I go on vacation to a new place, my family and I love to challenge each other to try to learn at least one new phrase of the native language. This summer, we went to Greece, and we loved doing Babbel's quick 10-minute Greek lesson as a family. I love Babbel because it's not overly academic. Babbel makes it fun and simple to learn a new language because the lessons are rooted in real-life situations like ordering food or asking for directions, so you can actually use what you learn. It also has speech recognition technology that helps improve your pronunciation and accent, which is highly helpful. If you're preparing for a trip or if learning a new language is on your 2024 bucket list, we have a special limited-time deal for our listeners. Right now, get up to 60% off your Babbel subscription, but only at Babbel.com/SHEMD. That's Babbel.com/SHEMD. Spelled BABBEL.com/SHEMD. Rules and restrictions may apply. Do you believe in metformin for longevity?
Yeah. Well, okay, so that is that's a complicated answer. So metformin, we know, decreases glucose production in the liver. We know that it has anti-inflammatory effects. We know that it has antioxidant effects. We know that in many people, it will cause a modest weight reduction. All sounds really good. It also increases lactic acid in the cells. And despite the fact that we've been using metformin for literally decades, we still understand how it works at the cellular and metabolic level poorly. And there have been many studies. There was one in 2014. I believe the primary author was Bannister. That was the study that I believe set off that metformin may be useful.
It was a flawed study, though, correct?
Well, so people are arguing a lot about this. Mm-hmm. And if you want me to go through those studies, I can. If you want me to just give you my opinion.
What's your opinion?
Yeah, so in patients who are hyperglycemic, I believe metformin is very, very helpful. In patients who have normal insulin and glucose metabolism, they're on the healthy side, and you want to take metformin for geroprotection, meaning as a longevity drug that you would advocate for almost anyone. I am not personally convinced that that should be the case, but there's also a lot of variability between people and how they respond to metformin, and it's also a safe drug to try. And I think it's okay if patients want to try it to see what is going to happen.
When you have a patient postmenopausal who's insulin resistant or at risk, have family history of diabetes, you can look at my lab results. And obviously there's some signs of insulin resistance. Would someone like me benefit from being on metformin?
Very likely, yeah.
Right.
And so for women in their reproductive childbearing years, they have a form of estrogen called estradiol, sometimes called E2. And that's the predominant form of estrogen, and it's the most potent form of estrogen. And there is evidence that that has some cardiovascular protective effect and some lipoprotein benefits. And when women approach menopause, they're premenopause, perimenopausal, and when they pass menopause, estradiol levels plummet. And it's a different form of estrogen, E1, I believe, estrone. And that is the weakest form of estrogen. And then what this causes is worsening LDL, worsening triglycerides, worsening HDL, more insulin resistance, more deposition of visceral adipose tissue, fat tissue. And it's just all around bad. And so if from a cardiovascular perspective, I would be more aggressive in treating their insulin resistance and lipoprotein abnormalities, especially around menopause, after menopause. And for hormone replacement therapy and the benefits that might have, that's a very controversial topic. I would refer you to an amazing physician I know, Thais Aliabadi, and you could talk to her about that.
We just did a menopause podcast. So, Dr. Ghalichi, can you talk to us about the ApoE test, dementia, Alzheimer's, and
I have one. You have one.
Yes.
We both each have one.
So talk to us about it.
Dementia, specifically Alzheimer's disease, which is the most common form of dementia, it's a huge clinical problem. Unfortunately, our treatment of existing dementia has not been very good. The prevention of dementia, there are some things that you can do, absolutely. One of the things that's often tested in this space is a gene called ApoE. And this is we know that Alzheimer's disease has a genetic component to it. So for example, if you take all patients with Alzheimer's disease as a group, 2/3 of them will have at least one copy of ApoE4. But in the general population, only 25% of people have one copy of E4. And so we know that there's a genetic component there. What I always tell patients when they test, especially if they come back with a E4 positive, is that it's not deterministic. There are many things you could do. Otherwise, there would be no point in testing it. In fact, there are some genes that they have a very high, what's called penetrance, where if you have that gene, you're essentially going to get dementia, and it's horrible. And the good thing is that it's only a small minority of patients, like 1% of patients, and we don't test for those. They can be tested for it, but there's very little we could do if that was the case. And it's usually obvious from their family history if they're going to have one of those.
So I know I have the ApoE gene, and I know you have one of the ApoE gene. What exactly is the ApoE gene?
The ApoE gene is a gene that codes for a protein called ApoE. And for all genes, we get 2 copies, one from mom, one from dad. And ApoE comes in 3 flavors, E2, E3, E4. All of human beings in an ancestral environment had E4. E4 is very pro-inflammatory. And what ApoE does is it supports astrocytes, which are brain cells that in turn support your neurons. About 50,000 years ago, E3 showed up on the scene. Most people are E3, E3. That's considered the normal wild type, the normal risk of dementia. That's a lifetime risk of dementia between 10 and 15%. And maybe 10,000 years ago, E2 showed up. And E2 it appears protective against dementia, and it's the least inflammatory flavor of it. So if you have one copy of E4, you're somewhere between 2 and 4 times more likely to develop dementia in your lifetime, but based on the correlation observational data. If you have 2 copies of E4, you're 8 to 12 times more likely. And about 2% of the population has 2 copies of E4. 25% of the population has 1 copy.
So let's say both Mary Alice and I, we have 1 copy of that ApoE4 on our report, which means we're like you said, 20 to 25% of the population carries 1 copy. What do we do to prevent dementia?
Yeah, so there are many things that are done and tried, and we have different levels of confidence about. And so at the top, where we have the most confidence for what are preventative measures that work, exercise dwarfs everything else. And cardiovascular exercise. That's right. And there's a recurring theme in research that what is good for the heart is good for the brain. And the brain needs a very efficient delivery of fuel and oxygen. And your cardiovascular system, if it's healthier, it can deliver that better. And so exercise is at the top of the list. Your sleep is also very important, not just the number of hours, but also the consistency. This could easily be an entire podcast by itself. Genetically, we are designed to sleep with the sun. Midnight is the middle of the night, not near the time where you start. Again, this is a whole conversation, but your sleep is really important. Another thing that's really, really important is not having type 2 diabetes. In other words, not having insulin resistance and being metabolically very healthy. That's really key. Another thing that's very important is good control of your lipoproteins, which prevents the plaque formation. You also get plaque formation in the head. There's a lot of evidence that preventing cardiovascular disease, preventing atherosclerotic vascular disease, preventing the plaque formation also prevents dementia. And this goes further and further. People laugh about this, but it's really serious. Not getting hit in the head over and over, so athletes, that really accelerates dementia. There are some molecules, supplements that are thought to be beneficial, that the evidence isn't totally clear, but they are used in these clinics that focus on the prevention of dementia. So for example, your brain is made of polyunsaturated fatty acids. And so keeping your omega-3 index up is something that they do and something I agree with. Your vitamin D metabolism, magnesium supplementation.
Is the same plaque in your heart, in your brain, is that the same problem? Because we talk about plaque in the heart and then plaque in the brain that causes dementia. Is it the same?
No. So for Alzheimer's disease, the plaques are neurofibrillary plaques, than amyloid and tau. It's different than vascular plaques in the arteries, but it is true that if you develop plaques in the arteries anywhere, that you're probably developing them in the brain as well, and then that affects the vascular flow. But when people say plaques for Alzheimer's disease, they're often referring to something else.
Okay.
Are you an endocrinologist, a primary care doctor, a cardiologist, and a neurologist?
Well, no. I'm an internal medicine physician and I'm a cardiologist. And all of this is intimately related to each other. And if you're interested in longevity, you really have to do all of it. If you don't die of this, but you die of something else, you still die. And again, it's very intimately related.
Well, I can ask you the same thing. I mean,
Yeah.
we had SZA on the other day and she said, well, she's my gynecologist, but she's also my therapist and my heart doctor. And so that's what makes you guys so extraordinary, is that you do know so much about other things. So to all of our listeners or viewers, if you're watching on YouTube and they are going to want to take the Boston Heart or the Quest test, there are different tests out there that they could take. But what are the 5 tests that they should be looking for to take?
I want to emphasize that the lab does not have to be any specific lab. And there are many good labs, and many people out there probably have access to a provider that uses Quest. Quest can do advanced lipids. They can do ApoB. They can do Lp(a), and it's shipped to Cleveland Heart. And it's a wonderful lab and it's wonderful results. Right. And so they absolutely can access it that way.
If you're 18 to 30, what should you be looking for?
If someone is interested in longevity, I wouldn't say that the 5 top things should even be a lab test. And if they wanted to optimize their health span, how long they're going to live, their quality of life, prevent frailty as they get older, prevent dementia. If they say when they want to get older, they want to still have their cognitive abilities, they don't want to be in pain, they don't want to be so fragile that when they fall, they shatter their pelvis, then the main levers that you can pull are exercise, nutrition, sleep, molecules, drugs, hormones, and I can't emphasize this enough, stress and emotional health, which is a big part of longevity as
We
well.
don't talk about that enough.
I think I fail all 5 categories, one after the other. I'm serious. I haven't slept in 30 years. Sometimes I'm too exhausted to exercise. I have genetic predisposition to insulin resistance. I mean, I fail every category you just mentioned.
But that's why you,
yes,
thank God you have
yes.
this amazing doctor.
Yes.
And most women don't have access to you. So it's really important on this podcast that we're giving them the tools. And it keeps coming back. And I keep saying this again and again. It's for your heart. It's for your brain. It's for menopause symptoms. It's exercise. It's sleep. It's anti-stress. So, and I know that sounds so simple, but it actually really is true. It's these are the top things that you can do even before you take a medication. And some people aren't even doing that. You are not getting enough sleep.
I know, like you sit here as a doctor and you tell me, well, you need to sleep and you need to decrease your stress. It's always easier said than done. How do I sleep when I get paid so many times a night? How do I, do you know what I'm saying? How do I lower my stress when I'm doing a million things a day? So, every new year, that's my resolution, to work less and sleep and do everything right. But somehow as a mom, as a working mom, it's impossible. And I know a lot of women
Feel the same way.
But thank you so much. I feel like you need to come back.
I know, you're amazing. And I wish everyone can see you. You look like you're 12 years old. No, I know you're not. Like, when did this happen that the biggest experts in the world are way younger than me at this point?
Well, I'll be 44 years old in May, so I appreciate that.
What is it because of longevity? Because you're taking your own medicine?
No.
And I tell you, I've practiced for so many years and I do referrals every single day for, multiple referrals per patient, whether it's cardiology, endocrinology, fertility. And one of the few doctors that I always on a regular basis get a call back and the patients are they're thanking my staff, or they call me and text me and thank me, is when I refer them to Dr. Ghalichi, because as you see, he's so comprehensive. Yeah. He goes into the detail from A to Z. He checks everything, whether it's your heart, your lipid panel, your risk for dementia, and in general. And I think every woman needs that.
We learned so much today.
I just want to say you're incredible. You're so knowledgeable. You know so much about everything. Most of us were really good at one thing, but to me, you know so much about everything in everybody else's field, which is really heartwarming. And I would love, love, love to bring you back here. So maybe we can talk about sleep. We can have an episode on dementia, whatever you want. I mean, we just want to educate our listeners to be their own advocate. I really wanted them to come and learn everything cholesterol related
and heart
related. And we really appreciate you coming here.
Thank you.
Well, honored to be here, and I would love to be back anytime. Thank you so much for having me.
Today, we've uncovered some key tests that can revolutionize how we approach cardiovascular health. 1, know your ApoB levels. It's a blood test that tells you the total amount of particles in your blood that contribute to plaque buildup in your arteries. 2, lipoprotein (a). This little-known test is a hidden gem when it comes to assessing your risk of plaque formation. It's a genetic factor that can fly under the radar in standard cholesterol tests, but it's a crucial piece of the puzzle in preventing heart disease. 3, ask your doctor about insulin resistance and metabolic disease. These factors play a huge role in your overall health and longevity, yet they often get overlooked in routine screenings. 4, If you have family history of dementia or Alzheimer's, check your ApoE genetic marker. This marker isn't just about your heart health. It can also give you insight into your risk of Alzheimer's or dementia. It's another reason why personalized testing is so important in assessing your individual risk factors. Thanks so much for joining us today on SHEMD. Follow us on social media at SHEMD Podcast and subscribe to our show on YouTube or wherever you get your podcasts. For Dr. Ghalichi's takeaways from today's episode, visit shemdpodcast.com.
This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SHEMD, some of the products and services we discuss may involve sponsorships or paid advertising.